My name is Gunjan. I am not an expert in either transgender health nor on sex-based medicine, but I've had some fun designing curricula on the subject. Notably, over the past couple of years, a few things happened. The AAMC, the Association of American Medical Colleges, released this brand new curriculum on how to teach students about sexual minorities, sexual dysmorphic disorders, transgenders, and we did a lot of research on that. And then at the same time, they also released and said we should be teaching about sex-based medicine. So the school sent me to Mayo Clinic last year, where I was lucky to attend a national conference on sex-based medicine. And I probably came back from that conference with more questions than I had answers. And so we thought, I thought when I do this, let me actually look at the topic and try to come up with, as a clinician, what we need to know about the subject. So just generally speaking, how many of you are familiar with the term sex and gender-based medicine? Show of hands. Okay, not a whole lot of us, which means it's a valid topic to talk about. So let's talk about what it is. Kathy? Yes. So gender-specific medicine, or the sex and gender-based medicine, is the study of looking at diseases that affect both men and women and look at the differences in them. How are diseases different in prevention, clinical signs, the approach to them, their prognosis, who lives longer with those diseases, their impact on the patient's life, and then to also understand why these differences exist. If the disease pathology is the same, why should it manifest differently in a man versus a woman, is the question that sex and gender-based medicine asks. So, I was talking to my friend, and she said, what are you talking about? And I said, just differences in men and women. And she said, I always thought my doctor knew that men were different from women. So for this topic, we're referring to the organs other than what would consider bikini medicine. So things in which men and women are the same or are what we will be talking about. We're not talking about reproductive health. We're not talking about breast cancer or diseases that occur in only one population versus the other. The basic concept is to make sure that every man and every woman receives the best health care. This is also not a health disparities talk. This is not a women's health talk. This is a pathophysiologic difference between how the same disease can present differently in different sexes and why and how. So for the record, it's always good to define sex and gender, because as I figured at that conference I went to, is that everybody was having different ideas. So one of the big things that NIH is saying is define stuff. So for this topic at hand, sex refers to a set of biological attributes. It is associated with physiologic features, with physical phenotypic features. It involves their genotype, it involves their hormones, it involves the biochemical processing. That is what you would refer to as sex, and also the anatomy. Most of the time, and this is something that we can have a conversation about, it is categorized as female or male. Now this has come under a lot of study recently. But at the same time, we've also said, even with phenotypic sex, there is a lot of variation. You've all read of chromosomal disorders, where life is not always, the clean and simple thing is XX and XY. But as physicians, you know that there is a lot of variation in between. But yes, for the most part, it's considered a binary dichotomous outcome. Gender is different from sex. Gender generally refers to the socially constructed roles, behaviors, often opportunities, expectations. So that influence both men and women, and also gender diverse people. It influences how they think of themselves, how people interact with them, and is probably responsible for a lot of the pathophysiologic things that we actually see in medicine. So and that's why they had to make this distinction, because not everything comes down to a difference between estrogen and testosterone. It also comes down to gender roles, how people are seen, how people behave, and how physicians see women versus how they see men. So there's a lot more to gender. So So for this definition, that's how we're going to talk about it. Gender, too, is often dichotomized. And we say the male gender or the male phenotype, and that on one end of the spectrum is the tall, bulky, muscular person, and on the other end of that spectrum is the frail, delicate, quiet woman. And some of you are smiling because we know a lot of women that don't necessarily fall in that end of the spectrum. And that again goes to, there are lots of women that might say, I'm not very feminine. There are lots of men that might actually be considered to be more feminine. So that is where gender comes in, is how they themselves perceive themselves, or we perceive how they behave. So going back, sex and gender medicine is looking at the differences in diseases between the two sexes and seeing, is that because of sex, is that because of gender, and what can we do about it? So just to begin with, we know men are different from women. Women have a survival advantage. The latest data shows that Americans are living longer than ever before. The average lifespan for a woman in this country currently is almost 81 years. The average lifespan for a man, however, is a few years behind. And that right away is a difference between men and women, right? So let's talk, and since the number one cause of death in the nation is heart disease, I thought we'll begin with sex and gender differences in heart disease. The other reason for starting with the heart is the cardiologists have actually done a mountain load of work in this field, much more so than other disciplines that are just waking up to the field. So we know sex differences in heart disease. We know that in the public, they've done this study again and again. They ask women, what are you more likely to die of, breast cancer or heart disease? And every woman will say breast cancer, and we've got all these TV commercials out there about save the tatas, and I'm not suggesting, my chairman sitting right here, that breast cancer is not important. It's just that women forget themselves that their number one killer is actually heart disease, not breast cancer. But if you ever talk about stuff, that's what you hear about. You hear about cervical cancer, ovarian cancer, breast cancer. So one of the big moves is to talk to women. It is the leading killer. And all of the studies that are done in this field are generally done on men. We know there are more differences. This is interesting, and I'll talk more about this. In the past 30 years, we've made a lot of advances in cardiovascular health, probably one of the most skyrocketing fields. And we've really reduced mortality for men. We have not been able to reduce mortality for women as much. In fact, data from the last NHANES sample show that MIs in younger women, I think we should have a slide on that. But even generally when we ask people if women get heart disease, when they do get it, everybody will say they get it at an older age, after menopause. Men get heart disease while young, women get it while late. Well, the latest NHANES survey showed that women are now developing heart disease at younger ages. While during that same age group of 35 to 54 years, MIs are actually falling in men, not falling in women. So I don't know if some people would remember the original article. This came out in 1991. This was the NEJM in one publication or that week's article. They had two studies. One showing that women are having significant heart disease, and that it was a fallacy because at that time we believed women don't get heart disease. And the second article in that same series showed that women are not getting the care they need. So the writer actually compared it with the story written by Sanger on how, I don't know if you guys have, if anybody's into old movies, this was Barbara Streisand's movie called The Yentl, in which this young woman wanted to be a doctor, but she wasn't allowed to be a doctor, so she pretended to be a man and lived as a man, so that she dressed as a man and lived as a man so that she could go to medical school. And that's how she became a physician. It's an old story. So the cardiologist linked it with that and said for a woman to be recognized as having heart disease, she's got to act like a man. Like you won't notice it till it is recognized as that. Can we walk this down, I think? So at that time, it was called the Yentl syndrome. Is that better? Yes, I think. You guys agree with me? Okay. The interesting thing was, we recognize, this is an old graphic. So as I told you, they recognized, so this is men, this is women. They became equal. Why is my pen not working? Somewhere in 84, we realized that women are actually having the same number of heart disease as men is. It took another 5 years, 6 years for us to get the data. In 1991 is when NEJM reported that actually women are having higher mortality. This is death in thousands, right? So they reported in 1991 that every year 20,000 more women die of heart disease than men do. And it still took us all the way till 1997 before we started doing studies looking at this very thing. That's when we began our health initiatives to see what was happening. So just so you know, while I have the picture on the earlier slide of Barbara Streisand and the, subsequently she worked with SUNY University downstate to start the Barbara Streisand Cardiovascular Health for Women Center, but it didn't happen overnight. It took 30 years for us to actually catch on to that information. And it's never changed. This is from the 2012 American College of Cardiology Proceedings. And again you see that even in women that have stable chest pain, it doesn't matter which race they belong to. Across the spectrum, they are always going to have a higher mortality than men. And when they come in with an acute coronary syndrome, they have a much higher mortality than men at all times. And this is even now, this is 2012. So while we could reduce the mortality in men for the past 30 years, we haven't been able to reduce the mortality in women, which is what begs the question of what is sex and gender medicine and what are we missing in this puzzle. And you guys know this, 42% of women that present to our hospital with an MI or any hospital with an MI will be dead within the year. But only a quarter of the men that have a heart attack will be dead within the year. So the 1 year mortality for women is still way higher than it is for men. And we talk, now one of the things that is often talked about is we know that women get heart disease at a later age. So they're going to have diabetes and they're going to have high blood pressure. So then we say maybe they were just older and that's why they died, because the men are getting it when they're younger. And they don't have so many comorbid conditions, which is challenged by the new data that says that women are also getting it younger. So let's talk about how sex changes this. And there are lots of studies. As I said, the cardiologists have done a lot of work. So coronary artery disease in men generally presents with less comorbidities. Most women that have CAD will have diabetes. And you guys know diabetes removes the protective effects of the female hormones. So a diabetic woman has the same cardiac risk as a postmenopausal woman. That it basically puts you at that biologic age. Men generally have an obstructive disease. When you do an angiogram, that's the classic picture that we see. Obstructive ischemic heart disease, 70% blockage, 80% blockage. Women don't present like that. When you do a cath on them, almost 1 in 4 women will be having ischemic heart disease, but will not have that one tight blockage. They actually have diffuse microvascular disease. And this has been shown, they've done, MUGA studies, radioactive studies on them, and this is connected with myocardial dysfunction. But again, it's not something that one can go in and open up with a balloon. So it's less amenable to treatment. Men have less inflammatory biomarkers, women generally have more. Men often present with plaque rupture, which often causes that, acute closure obstructive disease. And women generally present with more plaque erosion as such. Women also have more endothelial dysfunction than men do. This is what you would attribute to a sex difference. Maybe this is caused by their hormones. Maybe this is caused by their anatomy. Women also have smaller blood vessels. Maybe that's why they have microvascular disease. The way the inflammation works, it doesn't cause one set rupture. It causes small microerosions over time. But is there also a role for gender out here? Maybe women are communicating differently. And because that's how gender is. Gender is how they're perceived. Maybe I'm a woman and I've been there in the room with a patient and tried to just answer the simple question. And they don't. Women present differently. Maybe there's something going on there that we haven't attributed. So what we do know is that women wait more time. In the VIRGO study, 55% of women said that they waited for more than a day before they came into the hospital. And our house staff know that in heart disease, that is one of the key features in mortality, is the time in which we could reperfuse the heart. Most of the time, if they go to the doctor, I found this very interesting. It was statistically significant. 41% of the women will go to the doctor with a complaint of chest pain, but not necessarily mention a concern of heart disease. While men would most of the time would walk in and say, do I have a heart problem here? Women tend to discount their symptoms. And again, gender, remember, is not just how they perceive themselves, but also how people perceive them. So big difference, almost like a 20-point difference. 62% of the men in this study were told that there might be a problem with their heart. But even though women presented in this study with equal symptoms and actually worse comorbidities, less than half of them were told that's a problem with your heart. So it's also how we perceive our patients, how we perceive gender. And in case you're wondering, the study showed no difference between male physicians and female physicians. Female physicians are as likely to discount heart disease in females as male physicians are. And again, most of the men were the ones who said that our patient, our doctor thought it was our heart. And women also present differently. Though 87% of women will be presenting, is that 87? Yeah, with chest pain, which is the vast majority. In men, it's 90%. So most women will present with chest pain. The only difference is with that 13% that is left, they also present with a lot of these non-specific symptoms. Notably, the big one is nausea. Women also have less diaphoresis than men do, and very often complain of more fatigue. So again, that's the thing with gender, is maybe they're saying something, or maybe somebody's hearing something that was not said, which actually affects healthcare. Because we know that when a woman presents with heart disease, with chest pain to the hospital, as compared to a man that presents, there is 54% more angiograms are done in men than in women. So half the time a woman won't be offered an angiogram. And again, this is not a health disparities talk. This is a gender talk. Something about it makes us think they don't need an angiogram. Of those that get an angiogram, most of them don't get a PCI. And that might be related to the fact that they don't have like one obstructive lesion. That might be related to the anatomy of the disease, that they actually have microvascular disease. But this is what prompted the American College of Cardiology to start their new program, that Get With the Guidelines. You guys have seen that program? They've got some really cute infographics. It's called Get With the Guidelines. Because this is what we can't explain. Okay, we didn't do a PCI on them. Maybe they refused. Women don't like pain, maybe. But why were they not discharged on the right medicine? And we've done this again and again. We did this in the EuroHeart study. We did it in the Crusade study. Again and again, women are not discharged on the right medicine. So again, something somewhere is happening. And on that note, all of the studies show that women are likely to be less compliant. Now, compliance is very hard to measure. So there's a degree of subjectivity in this. But at least where heart medicines are concerned, there is data, which is not, again, that's what I want you to think about. How much of this is gender, how much of this is sex, and how much of this, at the end of the day, is something that you and I can modify so that we keep our patients safe. And going back to, it's not just about compliance, drugs work differently in people. And I've got some slides later on. Most of the drug research, most of pharmacokinetics is done in men. Very few drugs are tested in women. In fact, one of the big things that the cardiologists say again and again is that women are not little men. You know, we have a tendency to think of a woman as a little man. But that's not how they are. They're totally different animals to begin with. So the drugs don't work the same way. Some do. Beta blockers, calcium channel blockers work the same way. Big difference in aspirin. Big difference in aspirin. You know, in women, aspirin reduces stroke, does not reduce MI risk. So there is pharmacodynamic differences between the sexes that are not explained just by gender. And for that matter, ACE inhibitors in women have not been shown to work in asymptomatic patients. While in men, they also work in asymptomatic patients. So again, differences. And interestingly, device therapies, they've done some studies on CRTs. Women actually show a greater response, but very rarely are they offered device therapy. In fact, they even found that women were not offered ICDs as often, which is again part of the Get With the Guidelines. Even men are not offered ICDs as much as they should be, but especially lower for women, even though they've been shown to be more effective. And on that note, women have been shown to be less therapeutic on warfarin. Most of the time, it's very hard to keep them at a therapeutic level on warfarin, but they do really well with the NOACs. As compared to men, women actually show a better profile with the NOACs now. So there are some differences. And again, just to remember, there is 2 times the incidence of CHF in women. And the CHF that women have is predominantly of the heart failure with preserved ejection fraction. They don't have so much of a systolic dysfunction with dilated cardiomyopathy. They have preserved EF, which is sad because that's the one that we don't know how to treat very much, which might also be accounting for poorer outcomes. They have twice the increased morbidity and mortality of men if they have angina. And even when they go through a bypass surgery, they will have 2 times the increased mortality of men and morbidity from men from that surgery. And there are things in there that we don't understand why. I had to talk a little bit about AFib, just because this is so interesting that in a younger age group, AFib is equal. Men and women have equal rates, except when you look at people above 75, most of the patients with AFib are women. But you know why, right? Because women are living way longer. When you look at older people, you're always going to find more women in that mix. So it's not that something happens to women after that, you just find more women. What is important, and it's part of our CHADS-VASC little calculator that my residents check, is you have a worse outcomes if you're a woman. So you have a 2.5 times greater mortality than men if you have atrial fibrillation. Same disease, different prognoses. And you have 5 times the greater risk of stroke. And I'm not going to go into the gender stuff, but again, there's a lot of data that women are not offered anticoagulation as much. There was one study that said that people actually thought women are more likely to fall. I thought that was hilarious. But there's, again, that's gender perceptions. I'm not going to go into this, but again, there's a big difference of biologic factors. We've never figured out why women have so many more strokes with AFib, and that probably has to do with the molecular level inflammatory markers. They have higher fibrinogen levels. They have higher adhesion molecule levels. And again, the fact that they're often not therapeutic on Coumadin. Gender factors, and they've found this, women often report greater symptoms. Women often report less frequent episodes, but each episode lasts for a longer time, as in men. Men report frequent episodes, and they've done these, big cohort studies on this. And very often, women themselves don't present to the doctor because they think they're having a panic attack. When they start having the symptoms of palpitations, they themselves think, it's probably just my anxiety. They don't go in. And that's, again, the factor of gender coming in. So I thought I'd move straight from, since we're talking about AFib and strokes, we go from there to how it affects the brain. And there are big differences between the male brain and the female brain, even more so than I originally knew. So and this is a big part of the NIH initiative, every cell in the body, and that's the big thing, every cell has a sex, right? This doesn't want to move. Okay. And women will have 2 copies of the X chromosome. One comes from their mom and one comes from their dad. The difference is because each chromosome has such a high gene load, in the body, one of them is inactivated. The fun part, which makes it interesting, is it's actually different. So women are actually complete mosaics of cells, which is another reason even for why they don't get obstructive heart disease that has been put forth as an explanation. So you have a mosaic pattern. You have some cells where the X chromosome will actually be the paternal X chromosome that will be active, and in some other cells, it'll be the maternal X chromosome that is the active chromosome. And since they have different genes, it would have different manifestation. And what is most fascinating, so it differs in different organs. But in the brain, it actually differs from one part of the brain to the other part of the brain, and it may be different from the left brain to the right brain. I found this fascinating. I was like, that's why people always say women can't make up their mind. Their brain is not the same. Of course they can make up their mind. But in the most interesting part that I found, and it's not something you can predict. So if my brain has like more of my dad's X chromosome on my right hippocampus and more of my mom's chromosome on my left hippocampus, it's not going to be that way in every woman. Every woman, the brain cells are going to have a different active X chromosome, while the other X chromosome is just quiet. But fascinating, in mice at least, which could happen in women, I don't know, that mosaic pattern also changes. So 1 year it might actually be the paternal chromosome, and the next year in mice it has been shown to switch over to the other chromosome as cells grow and go through mitosis and meiosis and change. I thought that was fascinating. But what it does is it also gives us something to base our information on brain diseases on, because they do present very differently in men and women. So to begin with dementia, lots of conflicting studies. Some people say being a woman is a risk factor for dementia. There's quite some data on that. Harrison's actually says that. But I didn't find any, there are a lot of studies which say no difference. Some studies say after the age of 90, women are more likely to get dementia. I think that's just because after the age of 90, you're more likely to find women around again. We do know that vascular dementia is less common in women, and that makes no sense to me. After everything we talked about how women get more strokes, you would think women would have more vascular dementia versus men. But all the studies show that women don't get that much vascular dementia. They might be getting strokes, but they do get Alzheimer's a lot more than they do vascular dementia. And there's been a lot of research into why does Alzheimer's affect women differently. And that's, the disease has such a horrible outcome. It is a subject of great research. So there are a couple, and for this talk, I'm just talking about 3 things. So this is fascinating, but you all read about the ApoE gene in dementia, and we know it's a risk factor. Well, it is equally prevalent in men and women. So going back to the sex differences between men and women, the gene prevalence is the same. Men have the same risk of having the ApoE gene, and women have the same risk of having the ApoE gene. The difference is, it just affects women a lot more. Even when they've done studies on women that are the carrier for this gene, they have much greater atrophy, much greater cortical atrophy, and much worse memories as compared to men that are carrying the same gene. And that's probably related to our Mosaic chromosomal balance in the brain. They did another study, a large autopsy study, which said that they had a lot more of the pathologic findings, the amyloid plaques and the neurofibrillary tangles in the brains of women than in the brains of men. So even though the gene is prevalent equally, it affects women differently than it does men. The other risk factor that we talk about is hormones. So this was fascinating. Mayo Clinic had done a cohort study of women that had undergone oophorectomy. And I actually didn't know this till I was preparing for this talk. In women that had underwent a bilateral oophorectomy, before they would have become menopausal, like early, during a hysterectomy, whatever, age 35, 40, they had a higher long-term risk of dementia at the end of their life, which was negated if they were given hormone therapy till the age of 50 years. And this was even more interesting, even when they had a unilateral oophorectomy. Even then, there was an increased risk of cognitive decline. And this is really weird, because what I tell my patients all the time that come in that need HRT is we know from the Women's Health Initiative that when we give women HRT, we worsen dementia in them. And it all goes back to, I guess, it's not just that men and women are different animals, but I guess women before menopause is a different animal than women after menopause. Because that's the big difference. If you give hormones to postmenopausal women, you actually make dementia worse. Because you understand that's a different process. And the effects of estrogen on the brain are totally different in people less than 50. And they did find oophorectomy to be a major increased risk there. And then talking about gender-related risk, those would be, sex-related we talked about. We know that lower education is one of the big things for dementia. Now, across the world, and maybe more in some places than the others, there's a cultural concept of gender too. Just the fact that women had less education would predispose them to having a higher dementia. The fact that they weren't engaged in cognitively, demanding fields would have them to have more dementia. And that would be interesting to see because I think this was our 2013 rates. We actually have more women now in America that are graduating with a bachelor's degree and with a graduate degree. So that would be interesting to see if the trends change over the next 30, 40 years, what differences we see. Incidentally, they're still earning less money, but they are studying more. So maybe they'll get demented less. And I had to mention multiple sclerosis because this is fascinating too. For the past 30, 20 years or so, they've noticed the incidence of multiple sclerosis in men is about the same. But in women, it's increasing. And they've done a lot of studies on this, trying to figure out why it is. They did this giant cohort study out of Denmark, and they couldn't pinpoint everything, but one of the things they said was, well, women are smoking a lot more. they always try to put vitamin D in everything. So I don't know if I believe that information, but that's what the study said. And they were wondering whether the fact that women are having less pregnancies now, the average number of children a woman bears in the current world is a lot lesser than the average number of children a woman bore 50 years ago. And so one of the thoughts that they've put forth, like, let's study this, is that having a difference on the hormonal manipulation in the body? Now, I had to talk a little bit about the kidney because it is interesting, and it's opposite to everything else I've been saying so far. Because in a large meta-analysis that they did, I think that's some 400,000 patients or something, renal disease in women with ADPKD, IgA nephropathy, chronic renal disease of whatever, what we call our CKD thing, had a lower progression than men. So this is one of those things, where they actually appear differently, which, as I said in the beginning, this is not a women's health talk or a healthcare disparities in women's talk. This is just about how are they different. And it appears that kidney disease affects men worse than it does women. But again, the studies are very conflicting because it all depends upon the patient population you take. When they've taken older women, they haven't noticed that much of a difference. What they have noticed, and then there were 2 new studies which showed that while men have a worse progression, when they adjust for the level of proteinuria and for the level of blood pressure control, it's not that bad. Like, women are not that much better off. So it appears that what we thought that women are doing better may actually be a confounder because women have lower blood pressure than men in some of these studies. Again, that's something we don't know. But it is interesting because it puts forth some ideas about how we can help reduce CKD in men. So a couple things that they've looked at is there is a sex dimorphic adipokine, which is associated with renal decline in men, but in women it doesn't really do much. Same as the ApoE kind of messed up women, but didn't do anything to men. And I found this was interesting. I don't even know all of this very well, but they found that when they were checking people with nitric oxide synthase, in men the renal blood flow comes down, but in women it doesn't have any difference. And we know that NO synthase plays a big role in a lot of diseases with inflammation and endothelial dysfunction. So the question is, maybe those patients, women, do better. Thus opening up the gate that if we find a medicine to affect that, maybe we will be able to help men better. And again, we've talked about this before. There is eating changes. Women eat differently, women smoke differently. All of these other things that affect men and women differently that we don't know about. But I thought this was interesting. They basically assessed their hemodialysis database, and they had some 200,000 patients. And for across all age groups, in people with CKD, they always found more men than women on hemodialysis. And the next interesting thing was, men apparently get initiated on hemodialysis at a higher GFR level than women. Now, these are questions out there. This is why we have to talk about this when we bring up these questions. And this was even more interesting. Compared to women, apparently we initiate hemodialysis on men that are younger, less obese apparently, and more often they had coronary artery disease. And often had been already given a kidney transplant. And so the crazy part of this was in hemodialysis population, the whole survival benefit of being a woman was negated. So once you're on hemodialysis, the ratio for hemodialysis patients is back to 1. Women lose their survival advantage. And that's really interesting because all the men on hemodialysis were the ones with the heart disease and prior issues, and the women were actually not having the heart disease. They were older, but it's just interesting, but it totally negates the survival benefit that we talked about in the beginning, that women have about a 5-year survival advantage over men. And we can talk about that. And I promise I'm not going to go through the whole body. I just picked up 3 or 4 things that I thought were interesting. And after that, I thought I've made the point from now on they can just think about it. But there are some cool things about the liver that I did want to point out. And that's because we see a lot of this. I have one in the emergency room right now with this disease. And we know that hepatic damage will come sooner in women that are drinking. And it comes at lesser levels of alcohol intake than with men. And the relative risk of developing alcoholic cirrhosis is 7 in men with the same degree of alcohol and 17 in women. The relative risk is 3 of developing alcoholic liver disease, much more in 7. Again, why is it different? So is it because of gender stuff again, that a woman might be frowned upon? Again, how we look at people. So a woman goes to a bar, she gets 3 drinks, maybe people frown upon her, maybe she quits. Maybe a man goes, maybe he can drink more, I don't know. Maybe women feel guilty about drinking. Maybe women eat while drinking, or they don't eat while drinking. There's some stuff out there that women drink when they're sad, and men drink when they're happy. And I do not know if that is true. It was just an article I read. But again, differences is, but most importantly, men have 50% more of gastric alcohol dehydrogenase that breaks down alcohol. Women have a much lesser level, 50% less level of the enzyme that's going to break down alcohol. So naturally, their blood levels are going to be much higher. For the same intake of alcohol, women are going to have a much higher blood level. And then we know that women have less water, more fat. So in men, I guess that same dose of alcohol in the blood gets diluted out more, if you guys remember your pharmacodynamics and pharmacokinetics. And in women, there's a less volume of distribution. So that might be why they'll be having this. Again, the effect of estrogens on fibrosis is something that we've been talking about for a long time. So that is one thing that was interesting. The other interesting study I found was on Hep C infection rates. Now, this was fascinating because they had a cohort of pregnant women with hepatitis C, and they just watched and they followed the patients through the pregnancy outcome. And they found that the little girl babies were much more likely to get infected than the little male babies. And they put that down to maybe an inherent deficiency in the female fetus that cannot fight off an infection, and maybe the male fetus has an advantage out there. But what's really interesting is even in the older age, if in patients that acquire hepatitis C from needle-borne infections and stuff, apparently women get it much higher. And that might actually be related to a gender-based thing, because apparently women like to share, which is so nice, and get Hep C. And this is also interesting, and I don't know how important this is in today's world. I was talking with Dr. Morris, and he said, well, who cares anymore, because now everybody's getting better since they got their new drugs out there. But in the earlier days, they had a much better chance of virological cure if they were treating a woman premenopausal than postmenopausal. And this was something that I thought about, because I somehow, all these years of doing MELDs on my patients and figuring out, and we have somebody that we just talked about a MELD downstairs in the ER. When we do a MELD score, we take the creatinine. And just something to think about is the creatinine will always be lower in a woman than a man because they have less muscle mass. So I guess one of the questions that came out was, are we, doing a disservice to women by, instead of taking the creatinine, maybe we should take the GFR in the MELD score, and maybe we will get a more valid answer. So they actually did this study, and they found that when they corrected the MELD, it actually added 3 points in about 15% patients and 2 points in about 22% patients. But at the end of the day, at the end of 3 months and 6 months, when they looked at who died and who got a transplant, it had made no difference. But it was something that I was like, that actually makes sense. I would want them to change it and fix it to a GFR. And I was talking about this again with James and asking him, why didn't we? And he said, well, we never thought to look for that. And I guess that is the purpose of this whole talk, is, in all these years and all the research that we did, it's all about framing. You look at something with a certain glass and you find it. We always say the eyes can't see what the brain doesn't know. So maybe all these years, if we had had that little framework in our head, is that different in women versus men? Maybe we would have a lot more answers. But as he said, we weren't looking for that. And unless you go looking for something, you're not going to find it. I thought this was hilarious, by the way. And it's true. And this is out of 2014. This is part of the NIH initiative right now. We've talked about it. We said every cell has a sex. Every cell has the XX chromosome or the XY chromosome. Yet, all of our medicines, all of our pathophysiology comes out of cell-based research. Most of the publications do not specify the sex of the animal in animal-based studies, only 22%. Of those that do specify, 80% of the publications only use male sex. They say it's hard to get female hamsters or guinea pigs, or I don't know, it's complicated. And in cell research, again, the predominant 76% of the publications did not specify the sex of the cell. And we're testing new drugs on it, we're testing new enzymes on it, we're making new medicines without actually knowing if that cell is a female cell or a male cell, and without knowing if it actually works. So they concluded that there is a predominant sex bias in surgical biomedical research, and that we can't really just assume, as we said before, that women are little men and they'll work on women. So this was the Institute of Medicine report that they took out, and they said sex does matter. And I love this quote. She said, it matters in a way that we did not expect. So undoubtedly, it also matters in ways that we have not begun to imagine. You and I don't know all the different ways that maybe it affects diseases and pathology. So they basically published this, and they said that there's so much change, and we've talked about this before, so I'm not going, and that the sex chromosome genes are dependent upon the cell, dependent upon their different meiosis going on, the inactivation of the X chromosome, genetic imprinting, and they said that relative role of that sex chromosome and that mosaicicity, is that a word, is likely to explain a lot of these questions that we've not answered over these years. So then our new term is the sexome. I don't know if you guys had heard of that one before. We've heard the genome. So basically, this is our new understanding the sex-based effects on our gene networks. So looking at our genome, our human genome project, with the new framework, put the new sex-based glasses on, and look at that again. And that's what we're saying is hopefully going to save the world. Everything is supposed to save the world. And in 2016, the NIH did make a policy which said that on all new applications, it has to be, you have to address this as a concern. And they said you have to advocate, they're accountable, you make funding decisions fairly, that if people are not accounting for sex, that they not actually be given NIH funding, and then you sit down and analyze it and see if there is a gender difference in them. That's their new website. And at the same time, I'm not going to go through that, but the editors of all the medical journals sat down together and made the new SAGER guidelines, which said that, well, you got to use the term sex and gender very carefully. You can't confuse the two things, and that you should be noting them. And they're very detailed. In the title, you have to say that this is the sex-based difference, and the methods you have to. And they said in the discussion, you have to always imply, even if you didn't expect it, that's what they want. Even if you weren't expecting a sex-based difference, and even if that was not what you're studying, if you were just studying the effects of blood pressure treatment on proteinuria, they still want you to tell how many of them were male, female, and do a subgroup analysis to see if there was a difference in what, and figure that out.
So then in the table, do you say gender or sex?
Well, if it's an animal study, you say sex or gender. But if it's a cell-based study, then you would say sex.
But if it's a clinical study, people.
Then they are using, so if you used, this would be so confusing. For the SAGER guidelines, let's go back and see what they said. If you are looking at phenotypic things to define sex, like breasts equals females, then you would use sex.
Like if they got colon cancer screening.
Yes.
They would black or white, male or female.
They are saying it's sex in that case, male and female.
Sex.
Yes.
People say sex sometimes because it's shorter than gender.
That could be true. They say doctors use HCTZ because it's easy to say. So, I don't know. But, and on that note, I found this interesting. It always seems to me, and maybe I'm jaded. I thought I was young to be jaded. But anyway, maybe I'm jaded, but it seems that every few years the medical community just picks up on a new fad. And then that just becomes the thing. So these are all the websites that I found, all the books that have been written on sex and gender-based medicine. I found textbooks on sex and gender-based medicine in the ICU, sex and gender-based medicine in the ER, sex and gender-based medicine in primary care, in like every field. This is the new hot topic that we're talking about. We have all these websites. This is the Institute, the International Society, and these are all of the links that they had. We have Stanford with a center, Georgetown has a center, Johns Hopkins has a center. All of these, again, it just seems like the in thing to do, and maybe there is more to it. But this is what really, and again, maybe I'm jaded, but I found this fascinating that they actually made a registry of doctors that practice sex and gender-based medicine. And I was like, that's not a specialty. That's not you're going to do fellowship in sex and gender-based medicine. Like, this is just being aware of the fact that there's a lot we don't know, and maybe things are accounted for by sex, and maybe they're accounted for by gender. But I found that fascinating. And of that, what I found most fascinating is that in all of, and this is what happened at that conference I went to. People like me, when they're thinking, we were going to talk about transgender health, and about how sex is not binary anymore, and it's a continuum, and it's not dichotomous. And the organizers just wanted to talk about the XX and XY chromosome. And we actually had this conversation in that, where they were like, well, we're not talking about that stuff. And I said, well, you can't really have a talk about gender without talking about how people perceive themselves. But that is what is happening. At the same time as this is a fad, as I said, the AAMC, the IOM, everybody's also put out guidelines. JACO put out a new one saying that we need to be equally sensitive to people of all sexual minorities. And it just seems to me we're spending all this money and all of this information in studying sex-based differences, but we're still thinking of sex as binary. Even though we have a large volume of data which says that sex is not binary. And for me, it's fascinating that when I went on all their websites, they literally just refer to XX, XY. And that whole continuum in between is missed. And on that, I'm going to finish with this, is they've done studies on this, and I thought that was an apt thing, is we're completely out at sea. This was a study done in doctors and found that doctors are terribly unprepared when treating patients that are of transgender or sexual minorities. And maybe that's why we don't refer to that in sex-based medicine, because we don't know what to talk about. So I'm going to leave you out at sea. Hopefully, I raised some questions, and if nothing else, when you see somebody, I just want you to ask yourself, I wonder if it's that way. And that's, I guess, that is the question is, maybe now that we know that things are different, maybe if we start looking, we'll find a lot more differences. You know, our GI department did a study here on colon cancer. They've got a poster up on their wall, and they found that, you know, women had a higher mortality than men did. So maybe if we start looking, we'll find more differences. But I'm done. Any questions?
So, this is an interest of mine.
So surprising.
Yeah.
Why would an endocrinologist care?
So, one issue with animal research, which generally precedes human research in many cases, is that you more than double the cost of the study if you're trying to include females who in general will be younger, because who wants to keep animals around until they're old and then do studies on them. Well, for the same reason, so you're going to have cycling females. Are you going to try to time your study to a phase of the cycle? Does it matter? Oh, hell yes, it matters. And so there's just been that practical issue, apart from the fact, well, guys are who's important, you know, and that. But, you know, but apart from that, it's just a whole lot harder. I mean, I well remember learning about how somatostatin and growth hormone releasing factor are the yin-yang of regulation of growth hormone secretion. And then somebody let it slip. Oh, by the way, we have no data on females.
Never thought to see.
Yeah. I mean, at least they notice. You know.
So I'm not an expert, and God knows I've never done any animal research other than when I was young. Feed my neighbors, there were some bad things. I did find 2 new studies put out by the NIH which said that currently they do not foresee that the cost of doing studies on female animals is going to be more than that on male animals. And I'll send you the link, but I did find 2 studies that said the cost is something we thought of, and it's not really true. The other question is really interesting, and I don't know the answer to that, and we won't know till we do these studies. And maybe that's when we'll find out that there's even more information, and you're right, at a certain time, maybe women have different pathophysiologic mechanisms, at another time in their cycle it's different.
Well, there are lots of differences. I can tell you that circulating inflammatory mediators are higher at different times. Do these feed back to the CNS? Yes, they do, and so on and so on. Pretty much, if you look, you will find. And I mean, I completely agree with you. People just need to remember the extent of our ignorance.
That's it. Anybody else? Okay, thank you guys.